Welcome everyone to the April 13th, 2021 COVID-19 Clinical Rounds Critical Care Series. This one's on COVID-19 long haul syndrome. My name is Richard Hunt. I'm an emergency physician who serves as Senior Medical Advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer, real-time sharing of COVID-19 clinical challenges and successes. If I'm a clinician caring for COVID patients, the clinicians I want to learn from are the ones with the most experience. This is a voluntary public-private collaboration, thanks to the multiple professional organizations and societies who have collaborated on these rounds. We especially want to recognize a couple of organizations that last week joined as new collaborating organizations with these COVID-19 clinical rounds. Their logos are up on the banner head today. These rounds are not intended to be redundant or replace any organization's initiatives. They are intended, however, to be sharing of clinical experience rather than recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on clinicians learning from each other, their successes and challenges. Appreciation to the National Emerging Special Pathogen Training and Education Center, NETEC, for their support with these rounds. NETEC's webinars complement these Project ECHO COVID-19 clinical rounds. Thanks to Project ECHO, Dr. Bruce Struminger and his team for the peer-to-peer learning platform we use for these rounds. Upcoming ECHO COVID-19 clinical rounds currently are all US noon Eastern time. I always say US noon Eastern time, actually recognizing that we have participants that join our rounds from other countries and thus the US noon Eastern time. Mondays are EMS, Tuesdays are critical care, Thursdays are emergency department. This coming Thursdays will be an update on challenges and successes from Morristown Medical Center in New Jersey that has cared for over 3,000 COVID patients. The week of April 26th will be COVID-19 clinical rounds on vacation. We'll be taking a break and hope you will be taking a break as well, and hope you find something fun, joyful to do that will support your own mental wellness. ECHO will now go over some logistics. Turn this over now to Dr. Struminger. Thanks.
Thank you, Rick, and welcome everyone. And thanks for taking time out. Thanks to our participants, our presenters today, and our panelists for joining us. Just going to quickly go through housekeeping. We really love your questions and comments, so please share them with us in the Q&A feature at the bottom right of the Zoom toolbar. If you have any technical or logistic issues, please mention those in the chat. We'll be monitoring that and try to help you out as best we can. This session is being recorded, as it always is, and your attendance is consent to be recorded. Thank you. There's only going to be one PowerPoint presentation today, and we will share it after the session along with the recording on the Clinical Rounds website. And we'll share a link to that toward the end of the session. We're offering CME and continuing professional development credits through the University of New Mexico, where Project ECHO is based. We'll put a link in the chat about 15 minutes before the end of the session that takes you to an online anonymous survey. After 2 or 3 minutes, you'll get your instant CME. We really appreciate the feedback you share with us. It helps us improve the quality of these rounds and to prioritize upcoming topics. You'll have 48 hours to complete that survey and get the CME. Just as a reminder, these learning sessions are focused on improving patient care, health systems, and supporting clinicians. Please let's continue to keep them apolitical and non-commercial. Thank you for that. And just a note about data use. Your individual data is all kept confidential. Most of it is de-identified up front. What isn't, we de-identify before sharing with Rick and Asper, and they make great use of the polling results and the crowdsourcing that you share in making decisions. So thank you for that. Rick mentioned that NETEC is a partner in this initiative, and they have a great webinar series that, as Rick mentioned, often complements topics brought up here. We'll share a link to their website. They haven't yet announced the next upcoming webinars, but I'm sure they will soon. And the archive for all their webinars related to COVID-19 is there for you to access. Also, the American Association of Medical Colleges is a partner in these rounds. They have a great COVID-19 clinical guidance repository, which they update regularly, and we'll share a link to that as well. It's a great resource. With that, Rick, back to you for today's crowdsourcing question.
How is your organization supporting the care of post-COVID-19 syndrome long haul patients? Realizing there's a number of names out there for these patients with long-term sequelae and consequences of COVID-19. And as I put the question together, I sure am reading a lot about it in the paper, newspaper, and on social media, et cetera, et cetera. It'd be good to hear from my fellow clinicians on this one rather than just seeing it that way. And every once in a while, preprint article will show up too, but it'd be great if you could respond to this crowdsourced question. Thanks. And I'll now turn this over to our organizer and moderator for this round, Dr. Jeff Dichter. Jeff.
Thank you, Rick, and thank you, Bruce, very much. And to everybody, the crowdsourcing question is very near and dear to our hearts for this session. Our session is on COVID long haul syndrome, and I know it goes by other names. But for everybody who's on the call today, if you could let us know how your organization works with this based on the crowdsourcing question in the chat session, we'd be grateful. We read these things and pay a lot of attention to them. I'd like to thank our presenters for today, Dr. Ravindra Ganesh from the Mayo Clinic in Rochester, Minnesota, Dr. Angela Wong from UCSD Health in San Diego, California, and my colleagues from the University of Minnesota, Dr. Sharon Bazak, Dr. Tanya Melnick, and Dr. Leslie Moore. Grateful to all of you for being here, and I'm really excited to hear all that you're going to share with us. Dr. Ganesh, we'll go ahead and start with you if it's okay, and appreciate you.
All right, sounds good. Let me try to share my screen here. This is always my biggest.
Dr. Ganesh, did I mess up? Are you from Florida?
I went to Florida State for undergrad.
Appreciate that.
Yeah. All right, can you guys see my screen okay?
Yes.
All right. So today, thank you very much for allowing me to come and talk about post-acute sequelae of SARS-CoV-2 with a focus on long haulers. And as we've all mentioned, the initial question is what's really in a name? It has a lot of names. There's PASC, there's long haulers, there's post-COVID syndrome. And I think that getting the language clear will help us to communicate better in the space going forward. So PASC, or post-acute sequelae of SARS-CoV-2 infection, is an NIH term that really got coined in 2021. And it's an encompassing term for all the people who have persistent symptoms post-acute COVID. So this is going to include things that have tissue damage like myocarditis, pulmonary fibrosis, VTE, as well as the more syndromic stuff, which is a lot of what happens with a long hauler syndrome. And this has a lot of names as well. The one that we use here at Mayo is post-COVID syndrome, but there's long COVID, post-acute COVID, etc. The post-COVID syndrome itself does tend to have a very typical set of features as we've seen patients rolling in. And they're similar to many other post-infectious syndromes like post-Lyme and post-SARS that we had about 10 or 15 years ago. And there's also an overlap between this and some of the central sensitization disorders like chronic fatigue syndrome and fibromyalgia. And this has been kind of an issue that we've had with post-infectious syndromes in the past, where a lot of the symptoms are similar to these diseases. Now, I'm very sad that we're at this stage of learning, but in my career, I've never seen a disease where we've had to kind of work through it logistically from the very beginning. We've had to create an illness description. We have to do demographic studies for prevalence and risk factors, got to figure out pathogenesis, treatment, and prevention. We are here. this is all we have so far in terms of published data. We've managed to describe the symptoms of the illness, and we're starting to get prevalence and risk factors. And this is another thing that's kind of interesting about long hauler syndrome is that patients have been very instrumental in developing these definitions, because this really came to the limelight through a lot of patient advocacy groups. And a lot of data that you'll see on post-COVID syndrome is actually from patient advocacy groups, Facebook groups, survey groups. So what symptoms do we typically have here? Now, this is now a famous slide because it was the first post-COVID paper to actually hit the press that I'm aware of. And this was Carfey and JAMA in July 2020. They looked at hospitalized patients, and about 60 days after onset of symptoms, 80-something% had at least one symptom, typically fatigue, dyspnea, joint pain, and anosmia. This data is kind of mirrored in a lot of studies. I went through, there was something like 20-something last time I checked. But I want to show this one because it shows the emphasis that the patients have helped create by creating a larger data set. And they used 2,000 patients from 2 Facebook groups across Netherlands and Belgium, of which the majority were not hospitalized, so a different patient population from the one that we saw in the Carfey study. And they managed to get them around plus or minus 3 months. Symptoms were the same: fatigue, dyspnea, headache, chest tightness, cough, and kind of proceeded down. As you can see, there's a very wide array of symptoms people can have. And one of the things that was cool about this study was that they did a symptom map. And this is busy, but we'll walk through it. Basically, going this way, you have more symptom burden. And this is at the start of symptoms. This is towards the time when they followed people up. Symptom burden decreased in that more people moved into 1 to 5, then 6 to 10, then 11 to 15. But as you can see, at 79 days, there was still a significant amount of people still having symptoms. Local data from the University of Washington published this year. The important thing that this one adds was that 11 patients who they studied were asymptomatic at time of initial infection, but still wound up having post-COVID symptoms. And this is a 6-month follow-up. What do we know about demographics? Well, this data is still kind of mixed, and I think that it depends on which sample you're sampling from. And I think this is a case where meta-analysis may be very helpful. In this large group out of, I think it's out of England, they had 4,182 people in a community cohort, and it seemed that the odds ratio for men was a lot lower across age groups. And it seemed that kidney, heart, and lung disease were positive predictors for development of long COVID. Obesity was not predictive in this group, and age was a risk modifier, but not a discrete risk factor. However, the other study that looked at this was a study of 277 patients, of which 66% had severe disease. And in the more severe patient population, there was a trend towards males being more involved. Of course, it's not statistically significant, but the data is kind of all over the place in terms of what risk factors are present. What does seem to hold is that more severe disease and more comorbidities do tend to give you a higher risk of post-COVID syndrome, but this is not anything that any of us can hang a hat on, as it can occur across any demographic. In terms of management, well, that's really a good question. There are very few clear guidelines. The National Institute of Health and Clinical Excellence from the UK does have clinical guidelines, as does Greenhalgh, who published this very nice infographic in the BMJ last year. There's really not a lot of definitive treatment. The aim of both of these guidelines is to look for tissue damage based on whatever symptoms people have. If you find something, treat it. If you can't find something, work on supportive care with rehab, work restrictions, and kind of gradually rehabilitate people going forward. This is a dissatisfier for my patients because we have two different clinics at Mayo. One's the subacute clinic for people less than 3 months. One's a chronic clinic for people more than 3 months. And we both kind of use the same model where we look for tissue damage, and then we kind of get people into a rehabilitative program with slightly different focuses. The subacute program is really trying to get people back to work. And the chronic program is accepting that we're 3 months out and the likelihood of rapid recovery is lower. So we're working on gradually improving patients' quality of life and symptom management. And that's the current state of where we are. We know this is a syndrome. We know what symptoms people have. We have a vague idea of who gets it, but we still are at a position where we need a lot more knowledge on how best to do this. I'm going to go back to kind of the paradigm of kind of how do you understand the disease, because we don't understand the pathogenesis. There are lots of theories out there about immune dysregulation and whether there's some epigenetic modification that happens. We don't know what to do for treatment. There are a lot of things being tried. There are a couple of groups trying IL-6 inhibitors and things like that. I haven't heard definitive results on any of that. And then prevention, we have a little bit of a stronger footing on, because if you don't get COVID, you can't get post-COVID syndrome. So I'm going to take this plug to just say, vaccinate everybody you can. But we really don't know either. Our COVID treatments that we give in terms of COVID-directed therapy, are they going to be useful for preventing people from progressing to post-COVID syndrome? And so this is an area where we have more questions and answers. Hopefully, with this new NIH funding that's being released, by the end of the year, we might know more. But that's all I have. We're here. We need to get over here. Thank you.
Dr. Ganesh, thank you. That was really good. Appreciate it. Grateful. We'll go ahead and run through everybody's information, your presentations first, and then we'll go ahead and go to discussion. Dr. Angela Wong from UC San Diego Health, we'll go ahead and have you come back up next. And I think we're going to be sharing the slides for, oh, perfect, there they are. Go ahead.
Great, thanks very much. And I'm really glad to be here sharing our collective knowledge and also questions. This crowdsourcing approach, I think, is really a really innovative way to approach this. But I'm not going to spend a whole lot of time on the introduction, because that was just covered really marvelously. But I'm going to focus a little more on what we've been seeing here in San Diego. And I come at this from the approach of someone who spent the past 13 years as a community pulmonologist in private practice. And I came back to UCSD a year ago. So I really have kind of a very pragmatic approach into dealing with long COVID that I'm going to share with you. So I'm going to see if we could flip down to slide 6. The one just before it. Thank you. Right. So just again to recapitulate what was just said in terms of the symptoms that we're seeing. Here at UCSD, we have a multidisciplinary group that focuses on the care of our post-COVID patients. We have a pulmonary group that works with ID, rheum, neurology, cardiology, and we meet about every other week to kind of go over cases and share knowledge. Our experience has been a little bit different, I think, than that's been published. While we do see a number of patients who have fatigue and shortness of breath, obviously in a pulmonary clinic, we're seeing a lot more cough and chest pain and chest tightness. Difficulty sleeping, and also tachycardia, the heart rate and rhythm issues, probably a little bit more prominent on the pulmonary side than maybe in the general post-COVID area. And I use the word post-COVID lightly. I think someone in the comments suggested that what we're really dealing with is kind of overarching arc of a disease. And I think that's actually true. I think part of what we're getting into trouble with is that people think, oh, you know, you get this viral infection and then you're better, but really you're not, right? So I'm not sure this is sequelae versus just the ongoing manifestation of this viral infection. But be that as it may, what can we do for our patients? Next slide. So this is just a little sampling of what our pulmonary, one of our doctors in our pulmonary clinic has seen. Our patients on the pink bars are, they're separated by age, and on the left side, they're sliced out by obesity. And this is just a simple slicer dicer analysis from Epic. So, but because we're an outpatient clinic, our patients do tend to skew younger. We're seeing a lot of people in their 50s and actually 20s as well. And again, this kind of fits with patients who have mild to moderate disease who are never hospitalized. And as many other people have seen, they actually tend not to be obese. Next slide. And as other people have alluded to, our patients do tend to be female. It was kind of interesting to me because a large number of people actually do not state their gender, but at least of the ones that do state it, they tend to be female. There's a female predominance. Next slide. So in San Diego, obviously we have a large Latino population. So over on the far left, the blue bar, people who identified as Mexican. And then if you look, sorry, some of these labels are a little cut off, but 3 bars to the right, Mexican, American. So we have a large Hispanic population, which is pretty unique in terms of, I think, the published data. San Diego does not have a large Black community, and that's reflected as well in these bars because these are just pulling up the top 10 ethnicities, and being Black is not one of them. African American is kind of the turquoise bar, which you see that we only had like 2 patients out of the 85 or so that we've seen this year. Next slide. So this is kind of a visual map of the diagnosis that we're seeing in our pulmonary acute COVID. So we see a lot of cough and we see a lot of shortness of breath, right? So that's not unexpected for a pulmonary clinic. I think our approach to cough is pretty much, you know, what you would see would do as a general pulmonologist, and treating reactive airways disease, and also reflux. So it was sort of interesting to me when I pulled this up in Epic, because you can see that GERD actually ends up being probably the largest or one of the most significant diagnoses that we're seeing in this group of patients. And again, I think that's because of the concomitant cough that we're seeing in patients, but that's not something that I've seen in the literature. And I think I think that's just because people aren't asking, right? So, and that's one of the challenges, I think, in defining this post-COVID syndrome. Shortness of breath, asthma, tachycardia, as I mentioned, and we're also seeing a large number of people who have fatigue. And in the bottom right corner, the turquoise, orange, and blue bars are the fatigue and weakness that we're seeing in patients. Next slide. So in terms of the pulmonary issues, we're seeing, in terms of the shortness of breath, we're also seeing a lot of chest tightness. And on the whole, we're dividing the patients into 3 main groups. So they're the patients who present with chest tightness, many with cough, who appear to have some kind of post-viral reactive airways. Patients as a whole often have, if not a history of asthma, like childhood asthma, or some, history of reactive airways in the past, they have a family history of asthma. So I would say like in about 90 to 95% of patients, you can find some history, either personally or in their family, of reactive airways disease. And we know this like from other coronaviruses and respiratory viruses. So this is not unexpected. I think what's different about these patients is because of the anxiety and tachycardia, we're not able to use our kind of traditional dual ICS LABAs. Patients tend to be a little bit more sensitive to the beta agonist side effects of the anxiety, palpitations, and obviously tachycardia. So we're using a lot more ICS and either short-acting muscarinic agonist or LAMAs like Spiriva. And that seems to be actually working really well in terms of controlling the reactive airways component of it. In terms of the post-inflammatory pulmonary fibrosis and or organizing pneumonia, this tends to be seen obviously in our patients who were sicker, who were in the hospital. So not as much of a factor in our more general outpatient setting. We're seeing a lot of people who are just being put on steroids out in the community. We are not doing that. I think there's no data, and we're really, I think the other thing that we're seeing out here in the community is some people are actually starting to use anti-fibrotic medication, which I find personally really scary because again, the lack of data in terms of using these potentially very toxic medications is a little troubling, but I completely understand, right? I mean, you have a patient who's sitting in front of you who's short of breath, possibly still on oxygen, right? And what are you going to do? And I'd really love to hear what other people are doing in this group. And finally, in terms of the shortness of breath and chest tightness, we're seeing a lot of people, I think, who have respiratory muscle weakness. In the beginning, we were seeing obviously many patients on Zoom, and you could tell, right? I mean, just looking at them, right? A lot of people using accessory muscles. I mean, even just sitting at rest, and especially if you have them take a deep breath in front of you. And that's something that's actually been coming out in the press as well. Some of you may have seen literature from or articles from Britain where there are opera singers, right, treating patients with persistent symptoms after their COVID infection. Here in Southern California, we have a couple of groups now that are focusing on, I think, something, they call it breath work. And this is something that they're also doing at Johns Hopkins. It's not quite yoga, but it's actually something that is very focused on the mechanics of breathing. But it does have kind of similarities to yoga in that you are taught exercises and techniques, for instance, lying on your back, putting both your hands on your chest and your abdomen, lying on your stomach so that you can feel the front of your chest, but really having to reteach people how to breathe with your diaphragm. So we're starting to do a lot more neuromuscular studies. I'm not sure that there's a signal there. Some people we are able to detect a decrease in their MIP and MEP. We're also doing the MVV, and we're also doing the sitting and supine FVC. I'm hoping that we're going to be able to get one of our fellows with a portable ultrasound on his phone to kind of actually look at the diaphragm at the bedside. That's something that we're trying to organize. So short of doing a true sniff test, But these are kind of the things that we're starting to explore. And it's not unexpected, right? Because again, one of the most common symptoms that we're seeing is this kind of weakness. And what patients will tell you is that there's this profound lack of stamina and endurance, like even just getting up and doing a simple chore will leave them exhausted. And I'm not sure what that is. And so, whether that has to do with mitochondrial dysfunction or, the prolonged effects of COVID on skeletal muscle. Obviously, these are all areas for further analysis, but from a pragmatic standpoint, we're getting as many patients as we can into pulmonary rehab, and just getting them re-engaging in life, I think. And that was something, again, that was brought up in the last talk, that patients are depressed, anxious, and they're scared. They're scared because they don't know if they're going to be able to return to their former lives. They don't know if they're going to be who they were before this illness. So it's obviously a lot of work ahead, and I look forward again to hearing what others in the group are doing.
Angela, thank you so much. That was really, it's interesting when you focus on the pulmonary symptoms. I just didn't realize how many people had that many symptoms after their illness. Thank you so much. And we'll go ahead and hear from my colleagues from the University of Minnesota. And I don't know who's going to speak first, but it's Sharon Basic, Tanya Melnick, and Leslie Morse. And I'll let you guys go ahead and start.
Maybe I'll jump in and provide kind of an overview of how our approach to adult and pediatric post-COVID clinics evolved. And then I'll hand it off to Tanya and Bazak to talk a little bit about pediatric and adult care and some of the clinical observations that they've seen. Tanya and Bazak, does that sound okay with you guys? Hopefully they're still on. Well, late last summer, we collectively began to acknowledge system-wide that there was really a great need to address the concerns of patients with long-term symptoms after their COVID illness. And our medical leadership brought together a multidisciplinary group of clinicians involved in COVID clinical care and/or research to really create from the ground up a program to address these needs. And so I joined this group to represent physiatry, given the number of patients who were initially hospitalized and then required post-acute care prior to discharge home. And then the growing number of patients who were initially seen in our acute rehabilitation facility who reported lingering and persistent symptoms and who were seen for physiatric care after their hospitalization, but really stayed in that clinic with ongoing symptoms. We worked collaboratively with our ICU survivorship clinic, our primary care teams, our therapy teams, pediatricians, and other specialists, including pulmonology, to develop a clinical care pathway for our approach to COVID patients. And so our ICU survivorship clinic referrals are made for patients who were hospitalized and then intubated during their hospitalization for any cause, so not just COVID. But we saw many COVID patients referred to this clinic requiring ongoing pulmonary rehab, as well as treatment for PTSD and other related sequelae following their ICU stay. Adult and pediatric COVID clinic referrals are made for patients with confirmed COVID illness in our system and then symptoms for 1 month or more. And oftentimes we'll see patients who are referred both to the ICU survivorship clinic and also to the adult COVID clinic. And then a third pathway exists that can be direct referral to therapies, including physical therapy, occupational therapy, and pulmonary rehab and speech therapy. So we established our adult COVID clinic in the PM&R clinic to help with scheduling and care coordination, but have invited specialists with an interest in ongoing COVID care to join the team and to provide care in this clinic. We currently have 3 physiatrists, the pulmonologist, and an infectious disease physician working collaboratively to essentially do intake of these patients into the adult COVID clinic, and then coordinate appropriate referrals and ongoing clinical care, including therapies and neuropsychology. I'm just going to give you a really kind of high overview of some of my clinical observations. I have really been struck by, first of all, the need for this stream of care, and more broadly with the need for earlier involvement of a multidisciplinary approach that's really grounded in the identification and treatment of functional and cognitive impairments. And so I say this because I'm seeing patients with symptoms who have persisted for sometimes, almost a year, for the entire duration of the pandemic, who have not yet been referred for pulmonary rehab or for occupational therapy to help with energy conservation. People come with balance and weakness and haven't been referred yet for physical therapy. Almost all of my patients, the most common symptoms that I'm seeing in my clinic are fatigue and some form of cognitive impairment, either memory issues or brain fog. And so I have been making many referrals for neuropsychology. So I think that I will pause and let Tanya and Bazak give their kind of their clinical impressions as well.
Thank you, Leslie. I think I'm going to take on the adult part next, so Dr. Bazak can talk about pediatrics, which is very unique care, really has been underrepresented recently. So I have joined Dr. Morris and her colleagues in PM&R as an internist working with patients who had COVID, either on the ambulatory side or have been hospitalized for both continuity of care and assessment of really internal medicine issues. And those issues have been covered already by my colleagues. So thank you so much. And it really is strange to be an expert in a disease where we don't have a clear definition and we don't really know the prognosis and have difficulties guiding our patients in terms of expectations and even treatment to some degree. One thing that has struck me working with those patients that I actually heard from Dr. Wong's presentation, as well as the prevalence of anxiety, depression, and PTSD. Many patients, even those who had ambulatory course of illness, actually screened positive for post-traumatic stress disorder. And it does impact their rehab significantly, as well as their recovery. Oftentimes, those patients are told at the time of diagnosis that they need to watch out for severe symptoms, shortness of breath, difficulties just getting routine care done, and they're told to come to emergency room. So they spend about a week watching for those symptoms, and they go to emergency room when they start to feel very short of breath. At the emergency room, they're told, well, it's actually not bad, but come back if it gets worse. So they spend another week sitting at home, watching their symptoms, trying to figure out if it's really worse to the point where they need to go to emergency room, and frankly, being very scared, because the routine model of care where you don't feel great and you go to the doctor and you get help has been disrupted with COVID, particularly for patients who actually have COVID. They're told not to come in. They're told to come back only if they feel worse. And when they do come in when they feel worse, they're told, well, it can get even worse than that, and then we'll see you. So with all of that, they're just brewing in anxiety and uncertainty for about 2 weeks. So no wonder they're coming out with a lot of anxiety about how it's going to turn out and what their symptoms actually mean. And as a result, there has been a significant impact of that anxiety, even on their work with physical therapy and occupational therapy. They are afraid that some of the symptoms will get worse, so often they don't want to come in. Some of the symptoms actually do get worse. They start to feel very tired, they can get tachycardic, they can get short of breath, and they start to wonder if that's the right approach. So the support for those patients for their physical well-being is important. And at the same time, they need to work very closely with therapy, not just physical therapy and occupational therapy, but with psychotherapy, and kind of get over that anxiety that those symptoms, as they get worse with physical therapy and occupational therapy, mean that their illness is coming back. And same goes for post-traumatic stress disorder. I was really surprised. We're used to seeing some of the PTSD symptoms in patients who have been in the ICU. Now I have seen it in patients who had COVID on the ambulatory side and never been admitted to the hospital. So they have a lot of work ahead of them, and we have a lot of work ahead of us recognizing it and supporting those patients. So that's one of my observations. Another issue has been vaccine hesitancy in this group. And for those patients, again, that anxiety that they're going to start to have their symptoms again, and those symptoms can get worse. So we have seen that people who have mRNA vaccine and even Johnson & Johnson vaccine, because of vaccine reactogenicity, they can have fatigue, they can have fever, they can have some of the other symptoms. So those patients are so afraid to feel those symptoms again that it's going to resemble COVID. They often don't want to go and get vaccinated, even though most of the patients we're seeing now are basically potentially sitting ducks for having COVID again. They had it either in the first wave in the spring of last year, or they had it in the fall of last year. So it's been long enough where they might be at risk, and we really don't know what happens with patients who had COVID. Fortunately, it's not very common, but they can get sick again. So there's just not enough data on that. And we know that people who had COVID do react to the vaccine stronger compared to patients who never had it and get vaccinated. So trying to guide patients through that maze of, yes, your vaccine could be more severe, yet you really should get the vaccine because, hey, you could potentially get COVID again, and we don't know how your body's going to react to that with all the symptoms you're having already. That's been one of the biggest challenges too. So some patients have heard that the vaccine could make their symptoms go away and they could start to feel better. And that's been published in preprint at this point, and it's been published in mass media, so they do want to get vaccinated. But a group in UK, Body Politic, actually posted a few sort of patient stories where they got worse after getting vaccine, which is also possible. And that kind of persuaded some of my patients not to get vaccinated, or at least potentially consider Johnson & Johnson vaccine because it's a single shot. So if they have to go through worsening of illness, they're going to do it once, not twice. Well, now with Johnson & Johnson vaccine on hold, we're back to square one, where they may have to go through the vaccination series and potentially feel like that twice. So it's been very difficult, and trying to support patients and trying to really provide best data for that decision is not an easy task. But I think that's ahead of us, and hopefully we're going to get more information to really guide those patients and prevent them from getting COVID again. So I'll leave it off to Dr. Bazak.
So hello, and thank you so much for inviting me to talk here. So I'm kind of used to those panels to usually be the only pediatrician, and I think that also gives a lot of different insight and vantage point, because I think the way that in pediatrics we look at that is very, very, very different. And when I kind of realized how different it is was, I think it was somewhere in early fall when I started getting in contact with Dr. Melnick about creating the post-COVID clinic. And it was evident for me that the clinic that the adult side is building is a very kind of the ICU survivorship, discharge, And what I said on the first meeting was that we do not have that. So the vast majority of the pediatric patient never see the inside of the hospital. So pediatric COVID is a completely outpatient disease. So it completely have a different outlook. And I think that slowly everything else is being catch up, as we hear here, that it's not only those who are in the ICU or those who are admitted. So I think the pediatric, the experience with pediatric COVID really kind of gave us some different perspective to see that it is much wider problem than just bad acute COVID follow-up. And also personally, because I do infectious diseases and I do immunology and I do a hospital and I have a clinic. So I've been seeing kids with chronic Lyme and with EBVs and with pandas and with PANS for years and years and years. And when the post-COVID, long COVID, we're going to talk about the name in a second, my opinion about that. But when those patients came, I think it was very quickly, it was evident that there's nothing new here. Those are kind of the same patient, just different triggers and way more of them. So the way I'm looking at this problem is a bit different. It's a really outpatient, not really connected to what type of acute infection someone had before. It's kind of what they have now. The one common theme to everyone is that they were infected with the virus. And for me, this is kind of the one thing. The level of disease and the time and the exact symptoms are much more fluid as I look at that. And that also kind of brought us to the pediatric COVID, post-COVID clinic model, which I mean, it's all comers. We'll take anyone. We'll take referrals from the hospital. We'll take referrals from other doctors. We'll take community referrals. Everyone who had COVID or even think they had the infection and now they have some problem they did not have before, we'll be more than happy to see them because I believe that most of them are real. I mean, they have the real, physiological problem that sometimes are hard to identify. And just by bringing them all and see as many as possible of them, it helps understand. And also because they're so different, I see the COVID clinic as a hub, the medical home, not necessarily as a solving all problem. It's more of a triage. It's you come, you'll get the first appointment of exactly what's happening. What are your main problems? Is that school performance? Is that your physical activity? Do you have some heart problem that I need to send you to the cardiologist? And then we really try to establish a multidisciplinary collaboration, which means easy access to all the other referral clinics. It's easier to do in a big clinic, in the Department of Pediatrics. I have those all on a speed dial, and we've been working like that with patients before. So what we're trying to do is just plug those COVID patient with a variety of their problems into our existing infrastructure. And while doing that, have a continuous open communication with all of the clinics I'm referring to, saying, hey, this is something new or not new or whatnot, but we definitely need to sit together and build protocols. I mean, one of the main things we think about is protocols. What I can offer those patients, because even if I have a conversation and I explain to them, okay, we kind of understand what's going on, it's legit, those are real problem, it's not in your head. First, that discussion by itself helps a lot, I think, but also to tell, so I don't know exactly what to do with you, but here we are, a group of people who are interested, and we're working on that, and then you're in fact going to help us understand what to do. So this is kind of the approach we take in pediatrics. It's easier with pediatrics because they come with no other problems. I fully understand that. But that's why I also think that the pediatric and adolescents population are extremely important to learn from in understanding what really this disease is, because they kind of nothing else is going on with them except that virus that infected them, and now suddenly there are new symptoms. So I think it's also a great opportunity to learn from them. And also, we kind of spoke about pathogenesis. So again, being infectious diseases and doing immunology, and knowing that I've seen that before with the chronic Lyme and the EBVs and the pandas and the PANS and the chronic fatigue syndrome, I think it's quite obvious it's some sort of an autoimmune disease. I think there is more than just one process going on, but the way it's behave and the similarity to other diseases really make it look like an autoimmune disease. And that also want to bring me about the name. And there's a lot of time being spent about how to name that. And I personally think that we should spend a lot of time because I think the naming is extremely important. I think there are diseases out there that are named, the bad name they have really changed the way doctors look at them and patients are dealt with them. So I think this is something that we're in a unique situation that we can put the time and effort to think what will be the best name to really describe what's going on. Because I think, this PASC, and I like PASC because it's post-acute sequela of the SARS-CoV-2. It kind of puts the COVID-19 out of the equation, which I agree, because I think what we see with those long haulers, it's not the same disease. I think those are different diseases. I think the SARS-CoV-2 virus can infect a person, and I think it can give a variety of different presentations. One of them is what we call COVID-19, and that would kill so many people in the last year. It's a disease that I don't see as in pediatrics. I don't think I've seen a single person with a pulmonary presentation that I hear about it all the time. So even the sick pediatric patient I see that have the MISCI, it's a different disease. It's a very different disease, I think, from what my adult colleagues see. So I think also the longer term or the chronic is a different disease, that some people who had a bad acute disease will get that, but some people who had no symptom in their acute disease can still get that. So this is why I personally like PASC. I personally kind of every now and then tell my friend that I think we should name that COVID-20, because I think COVID-19 was a bad disease that appeared in 2019, and we've been dealing with that. And COVID-20, it's something that happened a couple of weeks or months later, and it's a disease by itself. So again, I never know how that will catch, but I definitely, in my mind, I kind of using that because it helps separate what those things are. And as I said, I think we are in a unique opportunity not only to learn what this specific disease is and how to help so many people who's going to get that, but there's a lot we can learn about other diseases. I'm excited for every research that's going to come out of MISCI, because that's going to make me understand Kawasaki much better. And I'm very excited about everything that's going to come out of PASC, because that's going to make me understand myalgic encephalitis and chronic fatigue syndrome much better. And suddenly you think about maybe we will have one day therapeutic options, because we spoke about, and someone put the question about the vaccines. I was the one that before I heard the anecdotal reports about the vaccine helping people, I was a bit scared of that. I thought if you will give the vaccine to someone that has some immune trigger to get sick, you might make things worse. But then we start seeing empirically that it probably the other way around, which opened a complete new avenue of a study. So, we can try to design a placebo control study of giving the vaccine to patients with PASC and see if it really helps, because if it does, maybe we will know how to treat all of the other chronic fatigue syndromes that right now we are really at loss with them. So again, overall, yeah.
Oh no, I just apologize. We've run through much of our time. I want to have a chance for the audience to ask questions here, and from our panelists. No, I apologize. I appreciate you. Panelists, do we have questions from the panelists? One of the things, I'll go ahead and start, is that listening to all the presentations, it's clear that we're still in the process of describing this, but yet a lot of patients have a lot of specific symptoms, whether it's respiratory symptoms as described by Dr. Wong, or physical therapy needs as described by Dr. Morris. So the question is, how it sounds to me, and I offer to anybody who want to answer this, is that we need to really think about COVID patients who are sick and go looking for this and provide support for them, rather than just saying go home and come back if you need us.
Hey, Jeff.
Leslie, would you go?
Yeah.
Sure, Rick, go ahead.
A couple of quick comments, of sort of like adding on to yours. Okay, so there was like a lot of like positive reactivity to NIH putting a lot of funding out there to, well, it depends on what you think a lot is, but funding out there for PASC, the long haul syndrome, et cetera. So that, yeah, the clinicians who are on this particular rounds have shared, these are real problems today. The research isn't gonna take care of those people right now. So the piece that I'm struggling with in trying to think about our approach to this, the here and now, is I think this kind of crowdsourcing, our ability to talk with each other as clinicians is absolutely critical. Maybe as critical, if maybe not more critical than early on, in that trying to identify things that are actually working for these long-term consequences are the approaches to the symptoms that we've used in the past for similar symptoms. Are they working just fine? Or are there novel approaches that quickly, a pulmonologist says, I've seen like 10 of these, I've used this, much like we did with the pronine way back when a year ago, like suddenly that seems to be working. Really making sure that, there's some good visibility of that, not like landing on that necessarily, but at least making sure there's visibility on it. Because it seems like, given everything with this disease, how new and winding paths it takes, try to identify those successes really quickly is going to be critical, because the research isn't going to be fast enough for these people.
Yeah, I think this is, in a way, an opportunity for us as clinicians who treat patients to go back to first principles, right? To go back to the classes that we took in training and physiology and lung mechanics. And, we've gotten very comfortable with this kind of guideline approach to treating disease. And we forget the basic principles that kind of underlie the physiology. And this is, I think, obviously there are no guidelines right now. And so, for instance, in terms of treating reactive airways disease or treating the asthma that we're seeing, right? It's going back to what do we know about airways inflammation and how to treat that? What do we know about the drugs and their side effects? No, we're not going to use beta agonists, even though there's Advair or whatever, but really thinking about what's driving the patient's symptoms in terms of their physiology and then targeting that. So it's not hopeless. And this is also very true about breathing mechanics, because I think a lot of us, at least from a pulmonary standpoint, we forget how we breathe. And, way back when, when we were taught, the diaphragm and the ribs, it's forcing us to kind of go back to that and really think about, what is work of breathing? What causes shortness of breath? And again, going back to first principles. And then the other point I was going to make was, I think sometimes we also forget that we're more than diagnosticians, right? I mean, ultimately, all of us who take care of patients are healers. And sometimes I think that gets lost. And this is when we don't have our usual gizmos and tools to reach for. Again, I think that's making a lot of us really dig deep and remember, our first principles in terms of who we were meant to be, in terms of healing people, treating the entire patient. Because I tell my patients, I am on this journey with you, right? So it's not, here's your inhaler, see you later. Again, so.
And I would like to add to that really quickly. So I have a lot of conversation with my residents and students about that. And, personally, as someone who is not the best board exam takers, I tell them this is a unique situation where no one in the world knows more than you. So this is really when you kind of use yourself. You kind of, again, I mean, I don't do breathing mechanics. I work kind of in, the immune infectious diseases world. But I really think it's an opportunity, and I keep on pushing it to the doctors around me and trainees to really, liberate themselves from the guidelines and really try to, again, don't do it yourself. This is why you need to have a group around you. But as a group, feel comfortable to do things that are not necessarily written anywhere, because if you're going to look for the written stuff, you're not going to find them in the next several years. So I think it's a great opportunity. And also the last thing is that you said, so, bit of a cliche, but Patch Adams in the movie said that if you treat a disease, you win some, you lose some. If you treat a patient, you will never lose. And that's exactly a good opportunity for that. So I think this is a great way. So, I personally, and I think many of us here on this panel enjoy that, because it really let us do more of us in medicine versus just, follow up guidelines.
I tend to agree with everyone here. One of the things that's really being helpful here is the groupthink. A lot of our divisions have come together and we're all thinking about this together. Pulmonary has been incredibly helpful and collaborative, as has physical medicine and neurology. And I think that we're all better for it, both as physicians and or patients. And I think that is the only way to kind of keep moving forward.
Yes, I agree. This has been a really unique opportunity to collaborate both with colleagues and also with patients. And I am fairly comfortable as a physician telling patients that I don't know. I have grown to be comfortable to saying, I don't know, and I don't know if anybody has an answer. As a general internist, for me, the answer, I don't know, usually means, well, I'm going to find somebody who knows. And this is a disease where we really don't know who will have the answer, and we don't know how to connect patients with those people. So it's gotten to be where we know some things that work in similar conditions, and let's go ahead and try it with you and see how it works for you. It really has become a trial N of one, thinking about it. Working with each patient, figuring out what symptoms they have, and kind of breaking up into chunks that are digestible. Okay, you have shortness of breath, you have fatigue. This is what we know works with shortness of breath for patients who have been in similar conditions. This is what we know works in fatigue. There is some overlap in terms of what you have to do with both pulmonary rehab and with physical therapy and occupational therapy. Let's get it all together, create a program for you before we have some therapeutics that really can help you and treat you. And really, it's been a collaborative effort with my physical medicine and rehab colleagues. So I'm very grateful to work with them. And we often talk about patients, hey, we're seeing this. What do we do in this situation? And same goes for pulmonary. I have seen them work with patients and basically saying, that doesn't look like it really is a pulmonary issue. I'm going to send you to the specialist. So there is a lot of cross referral that's going within our group, and even internal referrals. So if a patient has a lot of medical issues, they may be referred to me for follow-up instead of one of the physiatrists. And I do the same. So really it's who is the best fit for the patient and what is best for each patient. Yeah, it's difficult not to have guidelines, but I don't know if we're going to have guidelines for quite some time. And we have to rely on our experience and frankly, the experience with other conditions that we have seen before and treated before. And this is really exciting because some of the sort of abandoned conditions like chronic fatigue and fibromyalgia may get some answers as a result of it, because there is significant overlap in terms of what patients are describing with post-COVID. And because there are so many of them at this point, we can't just ignore it. We need to find answers.
One other thought that I'll ask, we'll go a few more minutes here. Is that it sounds like individualizing care for everybody and being empathetic with them is really important. For each of you, is there any particular pearl that you take away from having seen a lot of patients that really resonates? Something else that perhaps you haven't shared yet?
You know, one thing I was just thinking about is not overlooking sleep. So again, with the profound fatigue and that we're seeing in patients, sleep difficulties is actually a pretty prominent symptom in patients with prolonged COVID symptoms. And don't forget to do your home sleep studies, because we're actually seeing a not insignificant number of patients who end up having sleep apnea. And again, it's going back to first principles. You know, what are the things that we know that cause chronic fatigue and tiredness during the day? Sleep is important.
Absolutely.
For me, it's a holistic approach, and again, it's a very pediatric thing. Interesting, Dr. Wang, when you say sleep, I was like, of course, you need to sleep well, and then I saw you went to sleep apnea. I think that I don't even deal with.
Oh, right.
But the point is, so for instance, integrative medicine that I've been working with before just became my best friend. You know, suddenly you know who are the specific physical therapists who are more, because also in physical therapy, you know, for us provider, hey, send them to physical therapy. You realize some people doing sports, some people doing, you know, women health, some people doing kind of a long-term fatigue syndrome. And those are different techniques, those are different people. So it's really kind of trying to find, I think, the group that kind of agree and see that to what we all agree that it is kind of a bigger picture, and provide a very holistic, because as we all said, so many times I sit in front of the patient, I said, I don't know exactly what's going on with you. I do not know how to cure you, but I've seen that before, and I know that if you will do this, and that, it's not going to take it away. It's going to make it a bit better. Again, from doing the clinic work that I do, I am usually the last line after 2-3 years of chronic fatigue that they're going to rheumatology and endocrinology and pulmonology and all of those, and then they end up with me. And I spend time saying it's about time. You know, in medical school, they always teach us, find the source and treat it. But at one point, when you keep on doing that, you just get more frustrated, you spend money, you spend time, and it's not getting you anywhere. So sometimes you need to kind of do a complete shift of thought and say, you know what, something is going on with you. I do not know exactly what it is, happening for 3 years, so it's probably not going to kill you in the next couple of months. Let's deal with the symptoms. Let's kind of live around them. And that's where the integrative medicine and the physical therapy and the holistic approach is really useful. Again, pediatrics is different because they don't have the heart failure that, you know, many of your patients have also. But yeah,
we're also starting to work more with our integrative medicine folks. I mean, you know, I'm very open. I mean, access to techniques like acupuncture. You know, the DOs have this osteopathic manipulation, which is really good actually for relaxing the chest wall. And again, you know, chicken egg, what is it? That anxiety, the shortness of breath, the chest tightness, is it respiratory muscle weakness? I really don't know, but there are techniques that we know that can help, exactly as you're saying. And it may require you to reach out of your normal comfort zone to your colleagues that have different expertise.
Dr. Ganesh, one question I'll have for you, and I didn't mean to interrupt you here, but something I'll add to it, your thought, is that for us who work in the inpatient world, who may see some of these patients when they come back, are there things that we should be paying attention to? Yeah,
that's a great question. So a lot of times we divide the way we think about COVID into acute and kind of chronic, right? And the hospital question is always, what can we do to make sure you don't need to get intubated and go to the ICU, and what can we do to prolong survival? I think that what we're learning now, and we're seeing this in our post-ICU COVID patients, is that these guys have a lot of symptoms. They seem to have more post-COVID than kind of the rest of our populations. And, you know, it makes you wonder if early intervention would be more beneficial, like earlier pulmonary rehab, earlier activities, things like that. We've made strides with proning and things and steroids, but it does kind of make you wonder if there are more effective things we could be doing in the early stages. As a fibromyalgia chronic fatigue doctor in my other spare time, I'm very happy that we're bringing awareness, because it's going to help all of my patients, like Dr. Melnick said. And we've been doing a lot of crosstalk with the integrative folks as well. And it's been helping our patients. We don't have enough patients to have like data on a publication, but of the 50-something patients we put through, a good chunk of them are seeing significant improvement in symptom burden.
Thank you. All right, Rick, I think we've run 10 minutes over, but really grateful to all of our presenters and our panelists. Really, really good discussion. And so one of the things I always notice when we're running along is we're not losing a lot of our participants, and that's a good sign that we're all engaged in learning here. So thanks. I'll turn it back to you here, Rick.
Yeah, Jeff, thanks. Just before we sign off, I have one question for the panelists, and hopefully somebody will raise their hand because maybe they have a pearl of wisdom. But Jeff, you and Echo team and I, we talk a lot about our participants, and we have a broad range. And for each round, it's about a third nursing, about a third physicians, and about a third EMS. EMS is probably like about as distant from your clinical practices as I can imagine. But given we got maybe about a third of us on here who are EMS providers, is there anything they should know about these long haul patients, post-COVID patients? Because they're going to show, I mean, they're going to be responding to 911 calls, and they're going to show up. And then what? Then what do I do? Because I'm fatigued, or I've got I had COVID like a year ago and I'm still having a lot of respiratory difficulty. I mean, is there something that maybe they should know about from your perspective, realizing we're only a year into the disease? And if we don't have anything, that's good too. But on a final note, it'd be good for somebody to respond if you got any thoughts on that.
One thing that I have seen in our post-COVID clinic is I've seen far more VTE late than I thought I'd ever see. I've seen people at 6 months with massive clot. And that is something I think we should think about in the EMS setting, because if somebody has worsening dyspnea a few months out, it's not usually thought that it's a complication of the disease process, but with COVID, it does seem to be different.
Yeah, I would definitely second that. I just saw a patient who, was post-COVID. Oh, you're short of breath, you're post-COVID, but ended up having a clot. Yeah, but had just been dismissed as, post-COVID fatigue and shortness of breath. The clot was missed. So they still get serious illnesses.
Yeah, thanks, Angela. And Doug, I saw your hand up. Go for it.
I was just going to say that I think it just further exacerbates the issue we always have of trying to sort out, individuals with significant disease and complaints that are related to that versus other. And one of my observations is that, COVID has made this much more difficult because of the level of anxiety that is associated with this. I saw a lady in the emergency department last night that had some clearly unrelated symptoms, and she wasn't post-COVID, but she had received her vaccine a month ago, and she was convinced that what she was having is potentially due to the vaccine. And the number of EMS calls to our vaccination sites for what are not allergies but are clearly anxiety. And I think so this overlay of anxiety related to vaccines that are given immediately, to vaccines you had a month ago, to COVID you had a month ago, to COVID you had months and months ago, it just overlays all of this. It really makes it difficult for EMS as well as anybody in medicine.
Yeah, thanks very much. Jeff, thanks for letting me ask the question. And to our participants, particularly the 115, I see that hung on 15 minutes later, most appreciated, and appreciate your interest in the really great chat discussion that has been really fun to watch. And for our panelists, thank you for being on. To our presenters, Dr. Wang, Dr. Sharon, Dr. Ganesh, Tanya, good to see you over there across the way. And to Jeff, again, just applause to you for your extraordinary coordination of pulling all these experts, even though we don't know anything about it. Trying really hard to understand a disease and its long-term consequences. Most appreciated. Really, it's been a great session. And we got this brought to our attention many months ago by Vikram Mukherjee in the unit, and we're gonna just need to continue to hammer on this and try to figure it out together. So thank you all. Echo, thanks as always, and we'll see you on the next one. Bye.
Thank you, Rick. Thank you, Bruce. Thanks, everybody. Thank you for being here.
Thank you.
Thanks, everyone. Bye-bye.